So could you start off by introducing us to where you currently work?
Mm-hmm. Okay, so I'm currently at Richmond Hospital, clinical dietitian. I've had several positions at Richmond Hospital. So I started about 2 years ago, just as a casual, floating around the hospital.
Mm-hmm.
And I actually just recently changed positions to part-time in a different unit. It's called 6 North. It's more like medical, a little bit of surgery.
Oh, cool.
And I also work part-time now at what's called the Gill West Clinic, which has Hep C and HIV patients come in as outpatients. Yeah, basically, Richmond Hospital, I've honestly worked in every area, even like psych. We have some consults there once in a while. Um, and patients over there sometimes have eating disorders, mental health issues, those things.
Oh, cool.
But other units like cardiac, surgery, medical, telemetry, I've all covered there before.
That's awesome.
So yeah, hopefully I can give you some insight, not just on my current unit, but also around the hospital.
Yeah.
So yeah.
Great, thank you.
No problem.
I work multiple jobs. So with the Richmond Olympic Oval, I'm a private contractor that provides services whenever a sports team or individual wants a consultation or a lecture seminar. It's up to me really to accept or refuse any work that becomes available, because I am a contractor by position. But my other job, which is the one I'm currently at, is full-time with Vancouver Coastal Health as a dietitian that works within the Richmond Metabolic and Bariatric Surgery Program. So really, the sports nutrition side of my work, it's completely on my own, and it's just for passion. And so really, my 40 hours a week comes from Vancouver Coastal Health. The two different patient populations couldn't be more different, because at the Oval, it's more healthy people trying to achieve the top, let's say, 5% of fitness to pursue their sport, whereas with the Metabolic and Bariatric Surgery Program, I'm working with people who fall into our categories for consideration of bariatric surgery. So generally speaking, their BMI is well above 35 for the majority of the people we work with. So it's quite different and kind of see a very wide spectrum of care.
So over here we have two different programs, really. We have like residential care, and then we also have a rehab program. It's called Pathways to Home, so it's trying to get people that are no longer acute, but they're not quite safe to go home. So my role is spread across both of those programs. I also work in acute care too, so I guess I could comment on both of those as far as the prioritizing and screening. It's quite different in both of those roles. So I'm the sole charge dietitian at my position at Ponderosa for both of those programs.
Our first question is, what are some important considerations when prioritizing and screening patients and clients?
So I guess, like I said, that does depend on, the site that you're at.
So
it's a different process at both sites, but I think overall it also really depends on workload. It's sad to say that does come into play a lot. I guess I just wrote down a couple, point form here. And one important consideration is the diagnosis or the reason for visit. Comorbidities. Another one that I've noticed too is, I think also because I'm in Kamloops, it's a smaller community, so I do recognize patient and client names a lot from previous involvement, so that's another way to help prioritize and screen patients. But diet type and texture are a big concern too, and on our census that gets printed out every morning, we can see, if they're on a modified diet or a highly restrictive diet or one that might be inappropriate for them. Another one is nutrition support, so if they're on a tube feed or if they're on PN, they take a higher priority. We also consider if the discharge is pending, so if you're really the only reason they haven't been discharged yet, like they need clearance from our side, from nutritional clearance, or they need some education, and basically we're holding up the discharge, then they'll take higher priority. And another thing we consider is the referral source. So if it's coming from, a GI surgeon who's saying, I need a nutrition consult, I need a dietitian consult, that will take higher priority over, maybe a family member is referring.
Each day, and I'm pretty sure this is the same across all hospitals or anything in clinical, we have this form at Richmond Hospital we call it the census, and it basically has all the patients who want on your unit, and it includes obviously their name, their MRN, which is their specific number in the hospital, their diagnosis, and also a bunch of an area where it has their allergies and staff notes from the kitchen. So this is particular in Richmond Hospital, but each place has their own way of giving you like a patient list. And apart from the patient list, there's also most likely like a job description or some kind of form that tells you how to prioritize for that particular unit. So basically that form separates into low priority, medium priority, and high priority. So for example, high priority patients, under there it would have tube feeds, TPN, acute kidney injury, education, pending discharge, things like that absolutely should be seen within like 24 hours. And medium priority is something that should be seen within, like 2 to 4 days, something like that. And then low priority is stuff like if they're just older, maybe they're over 85, no other nutrition concerns, or they've come in with recurrent diabetic issues, things like that. It's lower priority. And each day you also get certain consults. You got calls from the unit saying, oh, you got to see this patient. And those ones will always be at the top.
So in terms of my role at VCH, when considering how to prioritize or screen patients, my current job really doesn't require me to prioritize. And you'll find that that's the same in any type of outpatient setting. Because in outpatients, we get scheduled patients. So we just see them all. We don't have to determine whether or not they have to be seen. However, as a VCH intern graduate, when I was working in a multitude of different areas as a casual, there are program-specific responsibility guidelines that dictate what that particular area would consider a high, medium, or low priority. And the other consideration is knowing roughly how long each type of visit will take you. So going in to see a patient for the very first time for an initial assessment may take you an hour in outpatients and maybe less than that in inpatients. But you also have to factor in how much time you require for charting afterwards. So given those numbers, you can actually, on a pretty good basis, be able to estimate how many people you can see in a day. So in order to screen efficiently, if your patient caseload was an acute care, let's say 30 patients on your ward, and you know based on time that you can only see anywhere from 4 to 5 to maybe 8 patients a day, in that case you would be able to determine who falls into, the must-sees. You also need to know what you're looking for. So in order to prioritize and screen, you need to know if for one particular patient you need to do a complete assessment of all their medications, supplements, blood work, history, current acute status, or it's simply a screening of labs, in which case you can do it without even having any personal FaceTime with the patient. You can just do that in the computer in a matter of minutes.
So would you be able to tell us a time when you struggled to prioritize multiple conditions within a patient? For example, if they have multiple comorbidities, and what should be tended first, or what area would you look at first?
Sure. So the example that I gave you was a patient that was referred to the Richmond Metabolic Bariatric Surgery Program for bariatric surgery, but this patient was already undergoing hemodialysis and has long-standing diabetes. And so we have 3 issues going on. There's morbid obesity, or class 3 obesity. There's hemodialysis, and there's diabetes. The blood sugars, I can't recall if they were well or poorly controlled, but in order to know what to tend to first, I needed to know what all the goals for surgical readiness for our program are. And so in this case, the measurables are for surgery. In order for them to actually qualify to be operated on safely, their BMI needs to be less than 60, their hemoglobin A1C needs to be below 8, and their weight needs to be either maintained or on a downward trend by following the healthy eating guidelines that we provide with our program. Now, those are the outcomes for surgery, but at the same time, the non-measurables are kind of healthy eating techniques that we provide them that are very specific to sleeve gastrectomies or Roux-en-Y operations, and also their understanding of the surgery as well. And that's pre-op. So in order to know what needed to be tended first, we need to see where is their BMI at, how well is their blood sugar controlled, and how is that reflected in their A1C, and what is their weight status. If we can kind of take a look at that and then also get a report from their renal dietitian and see how are their kidneys doing, then altogether we can piece this kind of person's health progress together to decide, okay, is this person truly ready to take on yet another life-changing surgery that is irreversible?
So with this one, I don't really have a specific example, but I do have more of a general example.
Okay.
So a lot of times we will get a consult for education, and that person, like you said, like a patient can have many comorbidities. So let's say they have, heart failure, diabetes, chronic kidney disease, and you get a consult for education. Just by looking at their reason for visit and their primary diagnosis, you might think that you have an idea of what that education piece should be about, and you kind of prioritize based on that, like what's more prevalent in that situation. But then you get up there, you meet the patient, and you realize that they don't want to talk about that at all. Their priority is something completely different.
Yeah.
Or you get up there and they actually want, they want answers to everything. They don't want you to pick a priority. They want you to talk about everything. So in both of those cases, it's really important to kind of work with the patient and you both together kind of determine what that priority should be. So I find it really hard to go in with your own idea of what the priority is. You always need to consider the patient or the client themselves, because that priority can absolutely change.
So I'll give you an example, and this happens all the time where patients have multiple comorbidities. It's actually almost expected now when I see a patient, if they're older, they have these issues. So someone has UTI and they get sepsis. And then they come to the hospital, they get treatment, and all of a sudden they get an AKI, which is acute kidney injury, and they also have a chronic heart failure. So you have issues with basically your entire body, your kidneys, your heart, right? And let's say you throw in fatty liver as well. So that's an issue with kidneys, heart, and liver, right? Usually what you want to do is only do the stuff where you can change nutritionally. So in a case like this, I probably look at the acute kidney injury first. So if they have AKI and their lights are out of whack, lights as in electrolytes, so their potassium might be really high, the sodium might be messed up, magnesium phosphate might be messed up, and these are the ones that we should pay attention to because that's where a lot of issues can come in. So for example, if the potassium high, you can recommend changing them to a renal diet. Or a low potassium diet. And that's something you can help right away. But keep in mind, when someone has a lot of comorbidities, the doctors are always on top of it too, right? So they're probably treating them with Lasix for their CHF. They're probably putting some medication to help bring their potassium back down. And at the same time, they're treating the main thing, which was the sepsis, right? And things like the fatty liver is something that can also be adjusted by diet, but that obviously takes more time and adjusting, eating lower fat foods, saturated fats, being healthier in general, right? So basically just do the ones that you can make an impact as best as you can right away. And a lot of the other stuff, medications and the doctors will kind of take care of that.
When you're looking through like a census or a client list, do you think there's any red flags that make you
Yep. Right away when I look at my census, if someone's NPO by the diet order, it's a huge red flag for me.
Okay.
Because if they put NPO, it could be a whole bunch of reasons. For example, if they recently had bowel surgery and they're NPO after surgery, then I realize, something might be up and they're not tolerating the fluid diet. It could be that they have an ileus, which means that there's poor motility in the gut,
Mm-hmm.
and it's being slowed down, and then that could cause a whole bunch of issues that might end up needing TPN. And yeah, so other reasons for NPO could just be they're going down for a CT or an X-ray or something,
Okay.
and it's only temporary, just a few hours, and they'll be back on a diet.
Mm-hmm.
That stuff I'm not worried about.
Okay.
For NPO, when it gets to being several days, 3, 4, 5, 6, 7 days,
Mm-hmm.
that's when it gets really concerning,
Yeah.
because then you got to consider tube feeding, or if it's an issue with the gut, then you want to consider maybe TPN. Other red flags for me would be any new patients, particularly new tube feed patients that get transferred to my unit.
Okay.
So within the hospital and within different hospitals like VGH and Richmond Hospital, there's often a lot of transfers each day.
Mm-hmm.
So if you've been working on a unit for a while, and then all of a sudden you go the next day and you see this new patient that got tube feeding, then you're like, okay, it's likely a transfer either from this hospital, within the hospital, or from a different hospital. Then you got to really research that a little bit and see where they're from, learn about it, because it's all new to you, but they're already on tube feeds.
Mm-hmm.
So you got to get right on it quickly.
Yeah, well, calling a time is, it was really easy. Like, when I worked at the ICU at VGH, basically everyone was urgent and everyone was severely acutely ill. The team as a whole determines that the sickest person is seen first, so that's out of my hands. Usually it's the intensivist that determines who gets to be seen first, and we start from there. You'd think it's kind of then the next sickest, then the next sickest, and truly that might be the case for the top 3, but because everyone's so severely ill, once we kind of see the top 3 sickest, at that point it's just geographically, if the beds are lined up a certain way, we literally just go then bed to bed to bed thereafter. In terms of, and also surgery. So in terms of in terms of surgery, at BGH as well, all the TPN patients are considered urgent because there's a TPN cutoff time, because the TPN bags are not actually created until the form is submitted, but it has to be usually submitted before 10 a.m. in order for all the bags to be created, delivered to the ward by 4 p.m., to be hung by the nurse hopefully by 5. And so you absolutely have to see all those people, but you would know to see them based on the program's specific responsibilities as mentioned earlier. In terms of red flags, when you're looking through a roster or a client list, they're generally in acute patients that are going to be discharged soon, or their admitting diagnosis is pertinent to GI. So it might be something like severe diarrhea or projectile vomiting, or newly diagnosed Crohn's, or diverticulitis, something like that. You'll either need to see the patient to do diet teaching before they leave, advocate that they're not nutritionally ready to leave, or perhaps you're seeing them for the first time, hopefully, before they leave. And what I mean by that is, in acute care, sometimes as a dietitian, you're faced with red flags on your roster, and to you it's a red flag. Like, oh, this person absolutely needs to be seen, newly diagnosed Crohn's disease, they won't know how to manage their diet, they're just going to be a revolving door and come right back to the hospital. But other members of the interdisciplinary team may disagree and already be discharging this patient home. So that's what I mean by advocate. You might have to see that and then ensure that the patient gets proper education before they go.
We would see first, for example, like I said, if their discharge is dependent on your involvement, so they're basically waiting for you to be involved. If they're going to be started on nutrition support, or if they're already on nutrition support and they have labs that are really concerning, like for example, you notice that there's some evidence of refeeding in their labs, or if they've been NPO for about, we always say like 5 days or more is a huge red flag.
Okay, yeah.
So those are kind of the top when we'd see them first. And then there's other things that we look at too as far as like diagnosis. Like if the diagnosis is something that's going to, or they're going to be nutritionally compromised, like we see a lot of bowel obstructions or esophageal cancer, strokes where they've failed a swallowing assessment. Those are all red flags that they're probably going to need our involvement. Or like newly diagnosed diabetes is another big red flag for us. I mean, these are the kind of red flags that are kind of across the board.
Yeah.
The problem is we might have, 10 patients that all have these red flags.
Yeah.
Okay. So that's when it gets a little bit more complicated.
So like continuing on to that fact that you're only one dietitian and there's like plenty of time constraints. When do you draw the line where you can say like these patients can be seen tomorrow?
There's not really a hard and fast rule for that, I guess. I mean, you have to consider like the red flags. Like let's say there's a patient who's got 2 of those red flags. That's something that probably can't wait for tomorrow. If you see like something that, for example, like you've been consulted for education purposes, but that tomorrow at noon they have a CT scan or something, so they're still going to be here for tomorrow at noon. They're going to be going to that CT scan, so you have a little bit of time.
Going along with the referrals and consults, should they be seen like as soon as possible, or like you said like it's dependent on like what the consult is, I guess?
It would depend on the reason for consult and also the source of the consult.
Oh.
Because I've noticed even in it's strange sometimes where you'll see someone who will have like 3 of these red flags, like they've been NPO for 5 or more days, they're newly diagnosed with Crohn's or something like that, and they have a diet that's highly restrictive, but you don't get a consult for that.
Oh.
Whereas you get a consult for another patient who the consult is for doesn't like pork or something like that. And you're thinking, okay, well, just because I got a consult doesn't necessarily mean that they're a higher priority than the other person who I didn't get a consult for some reason.
Okay.
So you have to use your own kind of clinical judgment as well.
Yeah. Thinking it through ourselves. Okay. Is there a way for when you're looking through either like rosters or you're attempting to like chart, well, for us, we're attempting to chart, is there a method or like a process you go through that helps you prioritize?
The most efficient way. I guess, honestly, everyone has their own style for that, to be honest. There's certain things that you take a quick look through and look for those, those
red flags.
Yeah, exactly. You kind of look for red flags and then go from there. Take like the first sweep over looking at the census is just looking for those red flags that we talked about.
I'll be honest with you, I have the most simplest way of prioritizing. I just will go through the list, but I'm kind of used to it now, so I don't have to go through like the high, medium, and low. I just kind of know right away, looking at the patients, and because I have knowledge of them from last week or yesterday, I'll label them as 1, 2, or 3. So 1 being the highest priority, I should try and see as soon as I can, 2 being moderate, and 3 being low. Now, the problem with this is it does get messy at the end of the day. My census looks like just a bunch of chicken scratches at the end, but I can read it. So, but nobody else can. That's the problem. So we have a method where we, at the end of the day, I think that honestly, this is one of the things at Regional Hospital that stands out between the other places is that we will update our info onto Computrition. So we update the information there so that when the patient's transferred or whatever, the next dietitian knows exactly what's going on with them, what we did with them that particular day.
Right.
And it also helps us because the next day we don't look at the census. We can be like, oh, these are notes I put for myself. Now I know what to do, what I did yesterday, right?
Yeah.
A lot of people like highlighting. I don't think I've actually encountered anyone who has done like flow charts, those type of things. And I think the reason for that would be it's just not enough time to do that. And I don't think it's necessary because when you start working on a unit, you just get so used to the patients. There's really no need for that. And you don't really have a day where you get such a huge influx of new patients to warrant doing that.
Thankfully, we don't have to. In acute care, again, you just follow the PSRs in order to determine who is a must-see with, and all of these PSRs that I'm speaking about have pretty specific guidelines. Like these conditions, as admitting diagnosis, need to be seen within 24 or 48 hours. The medium priorities may be 48 to 72, and then the low priorities may be, sometimes it's described as if you have time, or within 7 to 10 days.
Is there an effective method or way of charting that helped you efficiently to prioritize, i.e., like, did you use this flow chart or do you have a go-to method?
It's changed and evolved, but currently I find that the DAP method, which stands for Data Assessment and Plan, is great. So the plan part reminds you of what priority is next. If you're seeing a patient, whether face-to-face, in person, in acute care or outpatients, and it's imperative that, without being disrespectful of the patient, write down keywords and then try your best to formulate those into full sentences to complete your charting as soon as possible. Because if you see 2, 3, 5, 10, 12 patients a day, you will mix up that data. So in order to reduce the amount of time you spend in charting, the better your shorthand, no matter what method you choose. So DAP, later on, you'll be able to more effectively and accurately recall whatever it is that you need to document.
Great. And our last question for you is, if you would you do any of the above differently on a Thursday or Friday, because most health authorities don't have weekend coverage?
It doesn't apply to outpatients. For inpatients, on Thursday you just have to determine what your must-sees on Friday are, and then on Fridays the must-sees are people you think will be discharged over the weekend, such as doing diet teaching or needing a TPN or enteral nutrition adjustment. So in the past, I've left things such as standing orders, which really is if you're progressing, let's say, a tube feeding rate by 15 mils every day for somebody who's got poor tolerance of tube feeds, then you literally have to leave what the standing orders are for Friday, Saturday, Sunday, and potentially Monday, so that you're not in a hurry on Monday prioritizing for that day, then still trying to catch up on the patient that should be for the advanced Monday morning. It's already there, and the nurses can just follow that. And then other things like if the patient's going to be discharged on Friday, pending your visit, you should see that person before you leave, no matter how late you stay, or who's going to be discharged on a Saturday or a Sunday. So you need to know these things by Friday. And also people who may be dependent on you. Most of the time, well, not most of the time, but sometimes patients are ready to go and the bed is still being taken up because they need to see the dietitian for diet teaching, or you need to call their community dietitian, or you need to complete the tube feeding teaching or whatever it is that is still holding them up. So you just have to make sure that that's something you would do different. You have to wrap up nicely. And if it's a long weekend, you have to do that even better, because chances are there's even more of your patients are going to leave for over the weekend.
Yes, absolutely. Like your mindset on a Friday is very different from earlier in the week. Very different. That's a great question, because we do not have any RD. We don't even have an RD on call or anything over the weekend in any of our sites. So everything we do on a Friday is basically done as we work the whole week to try to create the less amount of craziness on a Friday as possible.
Okay.
So one big thing that we have to think about is any of our nutrition support people.
Mm-hmm.
So anyone who's on nutrition support and we're trying to get them, worked up to their goal or something, we'll start as early in the week as we can, and try to progress so that by the time they get to Friday, they're already at their goal. There's no need, there's very low risk of any complications over the weekend.
Mm-hmm.
So, and it always happens, it's like Friday afternoon, we get a consult to start nutrition support. That happens pretty much all the time.
Okay.
So, and that's when your mindset has to shift. So that's when you almost kind of, I don't want to say use the term band-aid a situation, but you want to basically take what you think is an immediate concern and deal with that immediate concern, and then create a follow-up plan for Monday. So, like for example, like we would get someone started on nutrition support, but we would start at a really low rate, and we wouldn't make any plans to progress over the weekend. We would just make sure that everything is safe, make sure the labs are ordered, make sure the monitoring process is all set in place, and just get things started as low risk as possible, and then reassess on Monday and create more of a detailed plan. Same thing for even like one of those education referrals on a Friday afternoon. If you're trying to get through all of your patients and their discharge is pending, like they're supposed to be discharged like the next morning, you would want to go see them. But instead of spending, if one of those people who wants to talk to you for half an hour, instead of being able to do that, you would more like give them a simple handout, give a little brief overview, and then either refer them to an outpatient program so that they have support later, or give them the number for, I don't know if you guys have ever used HealthLink CC.
811.
You talked about that at all? 811, yeah. We refer them to 811 a lot as well for continued support.
Okay.
So the mindset on a Friday is basically to make sure that everyone is as safe as possible.
So throughout the week, Monday is typically the busiest, obviously, because Saturday, Sunday, like you said, there's no coverage.
Yeah.
So Mondays, usually there's the most turnover, the newest patients. So you really have to be pretty quick and efficient with your prioritization. If you do a good job Monday, usually Tuesday, Wednesday, Thursday, midweek, you should be okay. Shouldn't be too stressful, shouldn't be too busy. And then Friday is where, like you said, you should try and prepare for the weekend. What that means is you could be writing some new orders, whether it's tube feeding, TPN, or diet requisition changes in advance. And I've done this before where I've written tube feed orders in advance, and I've talked to the doctor, I've talked to the nurse saying, hey, if the family decides they want tube feeding for this patient, because oftentimes it is a family decision whether they want it or not, I'm going to leave this order in the binder here, and you can use it on Saturday, Sunday if you'd like.
Oh, perfect.
So this just prepares everybody in advance, right? And really throughout the week, the way I approach things doesn't really change that much. I just try and be more efficient on Mondays and Fridays. We do have on-call coverage.
Oh, right.
So I think it's the same at bigger hospitals like VGH, but we have on-call. So someone takes the pager, and then whichever unit needs help, they'll call us on the weekend. But then we don't actually go in and do anything. We just kind of give them advice or tell them to write orders through the phone.
Okay.
Yeah, so we do have that, just in case there's something like really bad over the weekend. And in particular, TPN really needs on-call because when someone needs TPN, they want to get them started right away.
Yeah.
So we have a TPN pager for on-call and a regular pager for on-call here.
Okay. That is all my questions for today. Thank you so much for having this conversation with us. Thank you. Have a good day.